Alright, so let's go ahead and talk about the TIMI score in the risk stratification of patients with unstable angina or NSTEMIs. Now remember, when patients present with ischemic chest pain, we often do not know if they're having an episode of unstable angina or an NSTEMI. And this is because cardiac markers aren't initially detectable. And secondly, you can have both ST segment changes and or T-wave changes in both. Now often in unstable angina, those tend to be more transient, right? So we risk stratify and manage these patients the same way. Now the most commonly used tool to risk stratify these patients is the TIMI score, which involves 7 independent risk factors of mortality. Each positive risk factor counts as 1 point, so you can have a score anywhere from 0 to 7. Now to help me remember these, I use the mnemonic ACS, which is somewhat helpful. So 3 of these begin with the letter A. We have age greater than 65. We have angina, which is severe, meaning that there's been greater than or equal to 2 episodes within the last 24 hours. And then aspirin use in the past 7 days actually confers a greater mortality risk. Next we have 3 C's, so coronary artery disease risk factors. Now you need greater than 3 of these, but you also need to know what these are. So there's essentially 5 of these. And to remember these, let's just think of our friend Timmy for a second. So he's very well. Okay, Timmy, yes. Now calm yourself for a second, will you? So he's a very hyper guy, right? So we'll just say that he's hypertension, hypercholesterolemia, and we'll just also say he smokes, has diabetes, and a family history of CAD also. So that counts as 1 point since he has greater than 3 risk factors. So next is known coronary artery disease, which is stenosis anything greater than 50%. So these are people that have most likely been cathed in the past, and that's how they would know that. And then the last C is cardiac markers that are positive, or cardiac markers, which is what I say to remember it. And finally we have the S, which is ST changes greater than 0.5 millimeters, and this can be elevated or depressed. So we can prognosticate for our patients by tallying these points up and looking at the box in the top left of the screen. Now more importantly, we can also make therapeutical decisions based on this score. So for example, it was shown that patients with moderate to high risk, meaning a score greater than or equal to 3, benefited from an early invasive strategy such as PCI. A later analysis from that same study showed that the degree of troponin elevation and magnitude of ST segment deviation correlated with mortality from MI. It's also been shown that only patients with a score greater than or equal to 4 benefited from the addition of tyrofibin, which is the GP2B3A inhibitor. It's been shown that enoxaparin has a better 14-day and 6-week outcome versus unfractionated heparin. Benefits were primarily seen in high-risk patients with risk scores greater than or equal to 4 to 5. And one of the questions that has been asked is, are fibrinolytics recommended in patients with unstable angina or NSTEMIs? And the answer to that question is no, not according to the ACC/AHA 2007 guidelines. So fibrinolytics are not recommended in patients with UA or NSTEMIs. So in summary, the TIMI score is a relatively simple tool that can be used to both prognosticate and also provide important therapeutic decision making in patients presenting with either unstable angina or NSTEMIs. And thanks for joining me. I hope this was some use to you, and good luck if you use it in the future. And thanks for joining me. We'll see you later. Bye now.